Are you able to see the presentation?
Yes, we can. We can see the
You are seeing the presenter view, or you are seeing slideshow on your side?
On my side, it looks like slideshow. You can just try move the slides. We'll see if it's okay.
1 minute. Is it a slideshow or a presenter view?
Looks like a slideshow and it's moving.
Okay, thank you. Okay.
Yeah.
You let me know when to start.
We can actually begin. I think we have enough quorum. Thank you.
Good afternoon. This is a presentation we had discussed with the team to present a while back, but due to a lot of interruptions, it seems that we have finally gotten to it. It's going to be an extensive head injury, is very extensive, and it is very common. I'll do this presentation, then for 5 to 10 minutes, I'll do a small bit on pediatric head injury, because I put it as a separate slide. And I'll try to cover both mild head injury and severe head injury, because I know here we have a lot of doctors who deal mainly with mild head injury or head injury at the accident and emergency department, but also I know we have a group of us who deal with it in the ICU setup. So I'll try to cover both and try to be as extensive. As we are aware, it's the commonest cause of morbidity and mortality in our population, especially young population. And overall in the developing world, it's actually now the 4th commonest cause of death amongst all populations. Usually it results in injury to the brain, and the brain injury is usually most of the time from external forces, whether it's a motor vehicle accident, a fall, or a gunshot. So the injury depends on the impact, the nature. A person who has been fallen from first floor is not the same as a person who has been hit on the head with a rungu, or the same as somebody who has been shot with a machine gun. So all that intensity, the direction, and the duration of the force, which determine the pattern and the extent of the injuries. As I said, it's the leading cause of death and disability among young people globally. And especially in our setup, it has been increasing in incidence due to the increase in border borders. I'm sure each of you has a story on how either you have almost had a near miss with border borders, and in most of our accident and emergency, we are seeing a lot of border injuries, which are coming due to the poorly trained, and also lack of protective equipment. In the developing world, as I said, we still have motor vehicles and assaults account for the majority. But I was looking at data from Sweden, which shows that the majority of their population has moved from being 20 to 40 to now being 60 and above, because they're getting a lot of stroke patients who are on clopidogrel, who are on aspirin, who are on anticoagulants, and who get trivial falls, and that is the commonest cause in that. It's a silent epidemic because especially in patients with mild head injury, once we declare that they don't have any danger signs, we discharge them, but we forget that they are usually called, they suffer in silence because they have invisibility of the symptoms. You'll see they have occasional photophobia, a lack of concentration, headaches, and these ones usually are ignored because we are not aware of them. In the last, I think it was in 2016, showed that 10 million patients suffer from total traumatic brain injury, and the mortality at that time was at 9% of all which comes to around 90 to 100,000, which is a big number. And then you have also another 300 to 400,000 who get permanent disability, and the temporary disability is as high as more than 1.5 million. For us to understand head injury, we have to go back to a bit of physiology. Remember that especially in adults, the skull is a rigid bone which cannot expand. And so usually it has the brain, it has CSF, and it has blood. So whenever you have anything that results in a change in the volume of the tree, results in increase in intracranial pressure. And that can include in brain injury. It can be either because one, you have a clot, whether it's intracerebral, epidural, subdural, which causes an increase in the ICP. Sometimes you can have post-traumatic hydrocephalus due to the inflammation, and that can cause hydrocephalus, which worsens. And sometimes you can have the volume, blood volume changing. And sometimes even when you have ruptured aneurysms, especially in some patients you have seen who came in with trauma, but it was a trivial sign and the trauma was preceded by a ruptured aneurysm, and that one can cause. Remember that you can only compensate up to 50 mils, and that means that when the pressures are high, initially you try to push out the CSF up to around 20 to 50 mils. And if that is not able to do that, the next thing you try to do is that you try to push blood, and that's why you find the pressures go high, so that you can be able to accommodate the expansion. And the last thing that usually is affected is the brain, and that's where the herniation syndromes come in. If it's on one side, it can initially be a subfalcine herniation or an ankle herniation, but later it can come and become a tonsillar herniation resulting in brainstem death. So remember the cerebral perfusion pressure, which is the mean arterial pressure minus the intracranial pressure. So anytime you increase the intracranial pressure, for example, if it comes to all the way to 30, you'll find your mean arterial pressure it goes up, and so that it can try to maintain the cerebral perfusion pressure. And according to the Brain Trauma Foundation guidelines, you want to target a cerebral perfusion pressure of around 60 to 70. When you have a cerebral perfusion pressure below 40, you lose autoregulation. And what happens when you lose autoregulation? You are going to have vasodilatation of the vessels, and that results in worsening. It becomes a vicious cycle where it will cause an increase in ICP, which causes a decrease in cerebral perfusion pressure, and that worsens. And sometimes when the pressures are so high, like the ICP is 40 to 50 and your MAP is 40 to 50, you find that there's no blood flow going to the brain, and that results in cell death and brainstem death. So you always have to remember that the whole principle about head injury and the effects are mainly because of changes in intracranial pressure in the short term. And the second thing is that you need to remember there's primary brain injury and secondary brain injury. Primary brain injury is the injury which happened at the point of impact. And that is either whether a gunshot hit the parietal lobe and caused shearing forces through the parietal lobe, or the coup contra coup forces of a fall where you are hit on the front of the head, you hit the pavement, and then the brain is shaken, where you have a bruise on the frontal forehead, but on the occipital, you have a contusion hemorrhage. Those ones, we cannot do anything about them. And always remember that, and that should not be the target of your treatment. What we can do something about is the secondary. This is just a chart showing what happens when you have primary injury. And whatever pathway it goes, whether it's through release of calcium causing apoptosis or disruption of the cell membrane or the free radicals causing injuries, all of them result in this cell death. And that's what happens in primary brain injury. Secondary brain injury is anything, whether it is intracranial or systemic, that contributes to the primary brain injury cycle and results in greater tissue injury. And that can be either systemic insults. Systemic insults can include hypoglycemia, hyperglycemia, hypotension, especially for polytrauma patients, hypoxia. All those are systemic insults which worsen brain injury. Or intracranial insult. Intracranial insult can include 1, hydrocephalus, 2, you have clots, whether it's a subdural, epidural, or intracerebral hemorrhage. You have contusional hemorrhages which are expanding, and all those can worsen the primary brain injury. And all the targets of our treatment is usually based at that. And so when you see a patient in the emergency department, even if he has a gunshot, your aim is not to try to go and remove the bullet because that primary injury has happened, but it's trying to maintain the physiology. And here it's all about physiology, maintaining the physiology, whether it's glucose control, whether it's making sure the patient has no hypotension, the patient does not have hypoxia, because hypoxia worsens brain injury. And that's where we are going to discuss to a bit detail. Hypoxia, as you know, is when you have PaO2 below 90, 60, or SpO2 below 90. And it has been shown to double the mortality rate in patients who have traumatic brain injury. And most 40% at some point in the emergency department, and not in the ward, in the emergency department, usually exhibit hypoxia during the course of their treatment, and you have to look out for that. Remember that no matter what type of injury comes, whether it is head injury, whether it's abdominal injury, whether it is an orthopedic injury, the ABCs of trauma, air, breathing, circulation is never ignored. Hypotension. Initially, it's when you have the systolic blood pressure and it's normally below 90. And especially in severe head injury, it's common in a third to a half of the patients. And it results from hemorrhagic shock. You can have cardiac contusion. Remember the deadly dozens, whether it's a tension pneumothorax, tension pneumothorax, where you have an open pneumothorax, where you have a cardiac tamponade, a pericardial tamponade, cardiac contusion. All those are going to worsen your circulation. And when you cause hypotension, you are going to result in a reduction in the cerebral perfusion pressure, which is going to cause ischemia, and that also doubles mortality. So you can imagine if a patient has both hypoxia and hypotension, which is not attended to, you can increase the risk of mortality 4 times, 2 times, double from the hypoxia and double from the hypotension. Anemia. Anemia is where you have, especially HB below 7, you have to transfuse because you lose the oxygen carrying capacity of the blood, which results in hypoxia, and that causes a worsening. And sometimes you have hypocapnia and hypercapnia. Initially, we'll come back to that. I'll mention something about hypercapnia. Other things that can worsen is seizures, and especially early post-traumatic seizures have been shown to have a poor outcome. Electrolyte abnormalities, the most common is hyponatremia and hypernatremia, because it causes a change in fluid shift, which results in edema, and brain edema worsens the primary brain injury. You have coagulopathy, and this is where we are talking about. We are starting to see a lot of patients who have been on either rivaroxaban, Xarelto, on aspirin, or have been on clopidogrel. And so these patients come in with trivial trauma, like a fall. And then, but as they're in the unit, you find that their clot is expanding, and because of them being on anticoagulants, your hands are to some extent tied, because now you are afraid of the risk of bleeding intraoperatively vis-a-vis the risk of injuries. And luckily nowadays we have hematologists who assist us very much in the management of these patients. Infection has been shown to also worsen outcomes, especially ventilator-associated pneumonia, aspiration and pneumonia, which we seem to be seeing a lot of it, and hypothermia. Iatrogenic. Remember that sometimes you find that the resuscitation is inadequate. You find a patient comes with a GCS of 9 who has hypotension, and the patient is, because it's head injury, everyone prioritizes the CT scan over stabilizing the patients. Principles: no matter any patient who comes to the accident and emergency, ABCs override any imaging test. ABCs override every other thing, including splinting. Sometimes splinting of the femur is part of ABC, and you have to remember that. For intracranial insults, it's the intracranial hypertension, which we'll mention. We have lesions like subdural and epidural hematomas, depressed skull fractures. And remember that you have brain edema, which sometimes the patient is okay, and then the edema worsens over the next 48 to 72 hours. How do we classify head injury? We classify it according, the commonest is classification according to the severity, and that is the Glasgow Coma Scale. And I'll put a chart, but I usually employ even medical students and medical doctors and even registrars to go back and keep on refreshing your knowledge of Glasgow Coma Scale. It is mild, which is GCS from 13 to 15, moderate, which is 9 to 12. And the challenge with moderate is that because they're in between mild and severe, we don't have any guidelines which have been availed for management of moderate head injuries. And so here it relies a lot on the clinician's knowledge of both severe and mild head injury. And then severe head injury, where the patients are comatose and GCS is below 8. The most important thing, and you see I put it in bold, is that you cannot do the GCS when the blood pressure of the patient is between 60/30, or when the patient SpO2 is 65. You have to resuscitate the patient, adequately resuscitate the patient, and then do a Glasgow Coma Scale. Because if you do a Glasgow Coma Scale pre-resuscitation, it is usually very unreliable and will mislead you in your management. There's this category which has come up, which is a Glasgow Coma Scale of 15 and no loss of consciousness. These patients who report they were hit on the head but they just complain of a bit of headache, but they do not report any loss of consciousness or memory loss. And as I said, mild head injury, the two common things are loss of consciousness, amnesia, which I'll mention, or confusion. And then you have moderate and severe. This was when we looked at etiology. The commonest in our setup of developing world is still road traffic accidents, followed by assault and then falls. And we find that almost in our study in 2019, we found that 51% of all patients who came into our accident and emergency at Kenyatta had some evidence of alcohol intoxication, even though we were not able to do the blood alcohol levels. And this is just a chart of my study. And you can find that because the road traffic is still the commonest, even though because it had been divided, it was 46 plus 5, 51%, followed by assault. We get a lot of assault, especially either common amongst patients who have taken alcohol was assault by people known to them after disagreement, or also assault by unknown people is also common amongst the rest of the population. You are seeing we are not getting a lot of sports injury, it's only one, and we are getting falls where people are falling, and this one were two categories. It was guys who are intoxicated and fell off a height, or construction workers who work in areas where there are no enough protective mechanisms. You can also classify according to the type of injury. You can get these patients who have skull fractures without underlying, and the skull fractures can be linear. It can be depressed. It can be partially or completely depressed with or without dural injuries, and basilar or skull-based fractures, which I'll mention a bit later. You can have focal brain injuries, and here you can have the coup and contra-coup contusions, or you are hit on the side of the head and you get a temporal epidural hematoma and ICH, and the injury is focal to the area of the bleed. Or you can have diffuse brain injury, which can range from the mild concussion, which we usually call it the mild head injury, or diffuse axonal injury, which is more common in severe head injury. And the prognosis can be good in concussions and diffuse axonal poor. Clinical features. As I said, it's a spectrum, and it can range all the way from just headache and loss of consciousness for 5 minutes in patients with mild head injury, all the way to comatose in patients comatose with neurological lateralizing signs in patients with severe head injury. And you have to keep on evaluating. These patients must be evaluated every 3 to so often, as often as every 1 hour, so that you can identify deterioration quickly, because you might have a patient who has mild head injury, who had an epidural hematoma, who came in with a lucid interval, and the next minute you are called to be told that the patient's GCS is 5 and needs intubation and emergency surgery. And so you have to keep that at the back of your mind. Sorry, this is a very crowded slide. And so the clinical features, as I said, is that there was a confusion. And this, I just put it for the sake of the audience. You want to have a disturbance of vigilance, and patient is heightenedly distracted. As you are talking to him, he sees light or something and is distracted easily. They have an inability to maintain a train of thought. They are trying to tell you something and they keep on getting what you can consider to be thought blocks. And they have inability to carry out a sequence of goal-directed movements. And when you give them very simple instructions like write your name, they struggle. As they are starting to write, they forget, and they'll keep on asking you, what did you want me to write, or what am I doing? So that is the confusion. The amnesia, usually it's either anterograde or retrograde. In anterograde, it means that they remember until the time of the accident, but they cannot remember from the time of the accident until the time you are talking to them. They have a blank. Or retrograde, where they found themselves in hospital, but when you ask them what happened, they'll tell you an event which happened 2 hours prior to the accident. They cannot remember what happened prior to the accident. And the thing about most of the patients with this for mild head injury, most of the patients with amnesia, it usually improves slowly over a period of time. Some patients take a few hours, others can take as long as a week. So sometimes they don't have a loss of their data. They know their names. If you ask them who's this, they'll tell you, this is my wife, this is my son, this is my work colleague. And the duration, sometimes it depends on what was the severity of the injury and the location of the injury. Patients with temporal or frontal lobe contusions with a mild head injury tend to have a prolonged loss of memory. Loss of consciousness, it's usually because of the rotational forces around the area of the reticular activating system, and it can be temporary or permanent, temporary like in concussion, or it can be for long term in patients who have severe head injury. And remember that presence of loss of consciousness has no prognostic factor in terms of the long-term follow-up of patients with mild head injury. I'll put this up for the sake of the audience, and you'll find that when you're looking at the GCS, it usually has either you're having from eye opening, verbal, and motor. And I'll just put it up. It's found in any textbook. The most important you need to remember is the motor, because the motor has a bearing on outcome. So when you find that a patient who has a GCS of 7 and the motor is 2, vis-a-vis a patient with a GCS of 7 and the motor is 5, the patient with the motor of 2 has a poorer prognosis compared to the patient with the motor of 5, and that hence has more severe injuries compared to the 2. The examination always starts with A, B, C. Put up the monitoring, look at the SpO2. You want to maintain the SpO2, look at the SpO2. If it's low, you start supplemental oxygen. If the GCS is 8, you start identifying why most of the time head injury doesn't give you hypoxia. So you have to try to find out what else is causing the hypoxia. Does he have tension pneumothorax? Does he have secretions blocking their airway? Do they have did they wear any prosthesis which they have swallowed? So you have to dentures. And so after you look at the ABCs, now you come and look at the GCS, which you have mentioned, and you look at the pupillary size. Always examine the pupillary size, preferably in a dark room, sometimes difficult in our accident and emergency center. And so you want to try to find out, are they reacting? What is their size? Are they reacting? So you want to look out for anisocoria. Anisocoria means most likely there's ipsilateral ankle herniation, like in patients who have an epidural hematoma in the temporal lobe or a middle cranial fossa epidural hematoma. Another thing that is that they look out for bilateral fixed and dilated, and that usually is a poor sign. And it means that you are going to have poor neurological outcome. It means that the brain is starting to get advanced stages of brainstem dysfunction, and it means time is not on your side. And either way, you have to prepare the patient for relatives for a poor outcome. Neurological posturing, decorticate. Let me just switch on the video. Decorticate posturing is where you have the upper extremity flexion and lower extremity extension. And usually it tells you that there's an injury above the midbrain. And usually you have to be worried about it. It's usually where they have flexed both upper limbs and they have extended the lower limbs. But the one which is a poor indicator of outcome is the decerebrate posturing, where you have an arm extension, an internal rotation. So you have extension, lower upper and lower limb extremity extension with internal rotation and wrist flexion. And that usually tells you there's a severe injury, and these patients, if they survive, usually end up being in a persistent vegetative state. After you do that, you always have to come back and do a complete neurological examination, looking for subtle neurological deficit like facial nerve pulses. You want to look for features of skull-based fractures. Battle sign is usually when you have an bruising at the mastoid area. Then you can have CSF autorea, which is very common. Most of them resolve between 3 to 5 days in 95%, and you only intervene if it has persisted for more than two months. You can have CSF rhinorrhea, where you have CSF leaking, and whenever it pours on his shirt, you will find the halo sign. When you do an otoscopy, you'll find the patient can have a hemotympanum, and that is for the ones who don't have any autorea because they don't have a ruptured tympanic membrane. Other thing is the periorbital ecchymosis, so-called skull-based fracture. This is just to guide you for patients who have mild head injury or concussion. Sometimes you can divide the symptoms into cognitive, confusion, amnesia, disorientation, They tell you that I'm trying to do something, but I feel foggy, vacant stares, and excessive drowsiness. And you can have somatic, and the commonest somatic is headache, followed by dizziness, and sometimes visual blurring, and difficulty sleeping. So they end up getting insomnia. And sometimes they get emotional lability. Their close relatives or their wife or their brother will tell you that anytime you ask him something or you can't remember anything, he has outbursts. And sometimes they go into depression. I'll come back to a bit to the mild, but I'll just mention on severe. It accounts for 10% of patients with traumatic brain injury. And this is where you need aggressive treatment because of airway control, resuscitation, and admission to an ICU setting. Their mortality can be as high as 60% and sometimes higher in our setup. And the neurological exam, most of the time, you'll find a low GCS with abnormal neurological examination. Then remember the Cushing's triad, which means significant increase in intracranial pressure, and sometimes you might notice it even before you do the CT scan. You'll find the patient has progressive hypertension, which is coupled with a bradycardia and a chain stroke breathing. And here you can actually do an early intubation before CT scan, start mannitol, and try hyperventilation as a temporizing measure to allow you to do a CT scan. In setups which are a bit more advanced, which hopefully will reach, sometimes even they're able to do epidural hematoma. They're able to do bedside epidural hematoma by putting a barhole, being able to localize and putting a barhole, but that has to be done by the neurosurgery team. Imaging, skull X-ray not recommended because beyond showing you a fracture, it has no value in terms of assessing the brain. And the gold standard in head injury is usually CT scan. And the advantage of a CT scan is that it is readily available in most of our accident and emergency setup. It takes a very quick time, and it has high sensitivity, and there are no absolute contraindications. The reason I put this slide, and I'll go through it, is that remember that we have been having a challenge where we are over imaging patients who have head injury. And so you'll find every patient who comes to our accident and emergency is imaged. What I like is that if you go to Kenyatta in the room 9, which is the surgical room, you'll find there's a big poster which guides you through the Canadian CT head rule. And the Canadian CT head rule was designed by the team in Toronto to come up with to determine which patients will benefit from CT scan and what are the risks, what are the high risk and the moderate risk. The reason I come to it is that in our study, I did a study on mild head injury. We found that we were scanning 95% of every patient who came in with a mild head injury, irrespective of the symptoms. And so it's something that we need to go back to. One of the reasons that could explain why we have a high CT scan rates is one, majority of the scans were done prior to referral to Kenyatta National Hospital. And secondly, because we are a referral center, we only get the ones who need more advanced care, and that biased our outcomes. For high risk, these are the 5 things you look at. If you have any patient above 65 who reports a head injury, even if he has not lost consciousness, you have to do a CT scan. If you have vomiting 2 or more episodes, if you have a patient who you are suspecting, he might have an open or a depressed skull fracture with a deformity on the head, you have to do. And any patient who have a sign of base of skull fracture that we had mentioned. And at 2 hours, if the GCS is still less than 2 hours. Another thing is that if a patient has a retrograde amnesia of more than 30 minutes, this one you can decide, the NICE guidelines and the Canadian CT talk about either you can decide to image, or what they do in most of the other setups is that the patient is kept overnight in the accident and emergency center for observation. And by morning, if there are no deterioration, they are allowed to go home under supervision. And dangerous mechanism, what do you call a dangerous mechanism? If you fall from more than 3 feet, like if you fall from more than a meter, if you have an occupant who was not wearing a seatbelt and ejected from a car, or if you have a pedestrian who has been hit by a motorist, irrespective of whether they have loss of consciousness, you have to do a CT scan. Not you have to, you can opt to do a CT scan or keep them for observation. Next set is just criteria we use for also looking at patients who have cervical injury, because most patients with CT scan head, you want to do cervical screening. And if any of these patients meets either of the, does not meet any of these criteria, you will do a scan of the cervical spine. And if they meet any of these criteria, if they meet all these criteria, you will opt to observe. On the 95% of the 311 patients we looked at, only 34% had what we call clinically significant or clinically important brain injury. And in our setup, you can see that acute epidural hematoma was the commonest, followed by contusions. But the importance of the translation of this data was a good number of patients had either an epidural hematoma together with a cerebral contusion, or a patient had an intracerebral hemorrhage together with a depressed skull fracture. So up to 40% of the patients had more than one finding on CT scan. This is a patient we did a skull X-ray, and you can find, if you look at the skull X-ray, you can barely tell if the patient has a fracture. And when we did a CT scan as a comparison, you can see he had a depressed skull fracture which required intervention. And this, I've just put this slide just so that you can be familiar with them. This is a patient who had, both of these patients had epidurals. I just put so to re-emphasize. And you can see this patient with the epidural. How do I know it's an epidural? One, it is by convex, and you can find it by convex. Two, it is limited by the suture. Here, it's limited by the coronal suture anteriorly, unlike subdurals, which are not limited by sutures. And you can see, you cannot appreciate the ventricle on the ipsilateral side. You can appreciate the ventricles on the contralateral side. You cannot see the sulci or gyri. And or more importantly, you can tell the subfalcine herniation, as you can find, this is the midline. And so it was significant. This is also this similar patient. We managed both of them, it required craniotomy. And you can see this patient has also a biconvex subdural hematoma with midline shift, obliteration of the ipsilateral ventricles, and sulci and gyri have been obliterated. Of importance, if you look at this, because sometimes when you're looking at the scan, you just see an epidural and you forget to look at the rest of the scan. If you look at this scan, you can see there's a small contusion on the left temporal, and also you have contusional hemorrhages on the right temporal. And that's also important because it will explain why the patient's GCS might not come up immediately. I put this slide because you can see this first, this is a skull X-ray, and you can see how a skull X-ray is good at showing you a bullet fragment, because you can see there's no motion, there's no beaming artifact, and you are able to localize. And when we did a CT scan, you can see you struggle to see it because of the beam artifacts, and you have to keep that at the back of your mind. The reason I put this, I put this slide is because this is a patient, this was an elderly gentleman, a 68-year-old who had come in initially with a GCS of 13 and we did a CT scan. As we did the CT scan, as you are getting the CT scan, he convulsed, his GCS dropped to 5. And when you look at this, you can see that he had a massive epidural hematoma with subfalcine herniation, ankle herniation. Of also of significance is that you can see here there's a hypodensity. And this patient had had a PCA infarct prior, which will complicate his recovery later. But you can see this patient with all this atrophy. You can see he started getting hydrocephalus, a bit of hydrocephalus because of the subfalcine herniation. And this is the type of patient you want to take to theater immediately. Not 4 hours later, not 6 hours later, but as soon as you can get a theater. Sometimes you'll get a CT scan like this. A patient who had had either GCS of 13 or 12 has a moderate head injury, and you'll do a CT scan and all you're just seeing is atrophy. And you'll keep on wondering, why is this patient's GCS still low? And that's because sometimes they get shearing injury, and that shearing injury, they'll have a diffuse axonal injury where you are not able to observe any clinical abnormal finding on the CT scan, but still the recovery might be slow. These two slides are put for re-emphasis. This is an acute subdural. It's banana shaped or convex. It crosses all sutures. And the thing about subdural hematomas, acute subdural hematomas, is that unlike an epidural hematoma, subdural hematoma are a marker of underlying brain injury. And so you'll find most of these patients, when you go to operate, you'll find that they have contusions, there's the bruising of the brain, and you'll find that the brain is very swollen. And you can see this patient had a large acute subdural hematoma. His midline shift was 22 millimeters, and his GCS was 4. We went in, operated. This patient stayed in ICU for almost 2 months and still went home with went home after 6 months with a moderate disability. We'll look at that a bit later. And these are just the quick, for irrespective of any head injury, we usually have to go back to ABCs. What is the airways? If the airway has a problem, secure. Airway with cervical spine control. Before you clear the cervical spine, you have to put a collar until you're able to clear the cervical spine. If the GCS drops to below 8 or you have respiratory distress, you want to secure the airway. And sometimes the breathing you have to rule out. Does the patient have a hemothorax, a massive hemothorax, a tension pneumothorax, an open pneumothorax? Does he have a flail chest? Does he have airway obstruction? And if there's any of those, you want to be able to sort it out. Circulation. One of the reasons they have hypotension is because they may have bilateral femoral fractures. I remember we had one of our colleagues who was referred from a peripheral facility once. She was involved in a car accident and she was referred to Kenyatta. An intern was brought in by her colleagues. And because when she was being referred from the county referral hospital, everyone concentrated on the head injury and nobody concentrated on the other injuries. So by the time they were referring, they reported her GCS was 14. By the time she reached Kenyatta, her GCS was 3. And I remember at that time we intubated. What we noticed was that the patient had bilateral femoral fractures, which nobody noticed initially. Then when they noticed, because the priority of her colleagues and the nurses was, because this is a colleague, let's rush to Kenyatta as quick as possible. They decided nobody bothered to splint. By the time she was reaching Kenyatta, by the time we were doing the GCS, we did the HB, the BP had crashed. Her HB was 2.1. And eventually, a few hours later, we lost her. And that reminded us the importance of concentrating on management of polytrauma. If there's a fracture femur, you have to splint it because it will cause bleeding. And you know each thigh can keep 1.5 liters of blood. And so you have to keep that at the back of your mind. Sometimes you have, in pediatrics, a child can have brisk bleeding from the gallia, and that is enough to drop the blood pressures. Sometimes it's also important to rule out neurogenic shock or spinal shock in patients who also have concurrent spinal injury, which can explain why your patient is not responding to fluids. What are the admission criteria for patients with mild head injury? 1 is a GCS less than 15 at the time in casualty. And so you'll find even afterwards, the GCS is less than 15, they are 13 or 12, no 14, or 2 hours later, 3 hours later, that patient must be admitted for neuro observation. 2, an abnormal CT scan. It can be as abnormal as a big epidural hematoma, or it can be just multiple contusions. Because sometimes you have coalition of the contusions, which can result in deterioration of the patient. 3, a patient who reports more than seizures, especially seizures which are noted also in the accident and emergency center. And 4, patients who have abnormal bleeding parameters, either they are on anticoagulation for a long period of time, or they have a bleeding diastasis, like we had once a patient who had hemophilia, who was involved in a road traffic accident and had an ICH. But we couldn't operate because his factor VIII was low. And by the time we were corrected, the mass effect had reduced. So that is a patient who you must admit. Another patient who is admitted is a patient who cannot be observed at home. Either patients who live alone and they don't have somebody who can oversee them, or a patient, like you'll find we get a lot of street children who come in, or homeless patients who come in, and even if you release them, they'll go back to the streets. That's a patient you have to admit for neuro-observation. When do you discharge? Whenever you're discharging, you have to discharge these patients. You have to discharge these patients with a note, a written and an oral discharge instructions telling them the danger signs and when to come back. I'll go through the danger signs, but if the GCS is 15, has a normal neurological exam, either has clinically insignificant injuries like contusions less than 5 millimeters, or no predisposition for bleeding. And more importantly, they should be able to be observed by somebody who can bring them back to hospital if anything changes. What are the danger signs? 1, severe headache, which is unresponsive to simple analgesics. 2, if a patient gets seizures, 1 or 2 episodes of seizures, they have to be returned to the accident and emergency immediately. 3, a patient who did not have any neurological deficit starts developing new deficits like weakness, right-sided weakness, or a patient who starts developing facial nerve palsy, they should come back and require immediate CT scan. 4, a patient who is discharged and now they are struggling to wake him up, the mother reports that they are unable to wake them up. They have inability to awaken or to be woken up. And 4, vomiting more than 2 episodes, fevers or neck stiffness, especially for a patient who had had a CSF leak or skull-base fracture. And 5, confusion or visual difficulties. Any of these are danger signs which should be explained to the next of kin and should warrant the patient coming back immediately. I'll go to severe head injury. And we had mentioned this. Half of the patients who have severe head injury have other polytrauma or other injuries, and you usually have to do the primary survey followed by the secondary survey and trauma series. Monitoring important is SpO2, blood pressure. You have to look at the urine output, and you have to do a continuous cardiac monitoring. What are our goals of treatment in patients who have severe head injury? 1, you want to prevent secondary brain injury, which means prevent hypoxia, prevent hypotension, correct anemia, prevent hypo or hyperglycemia, both of them. If there's a mass, you want to evacuate to avoid hypothermia because it's related with poor outcome, and you want to prevent all that. So one of the things that you have to consider is that, I'll come back to it a bit later, is that I'll come back to the airway control, but this is the head injury has happened, the primary, and you have systemic insult, which causes cerebral ischemia, and which can also cause, together with the primary injury and the intracranial lesion, and all of them result in brain edema, which results in cell death and brain swelling. I'll put up two scores which are important for CT scan in severe head injury. You can find that there's a Marshall score. The Marshall score looked at CT scan in relation to the findings. It goes from grade 1 to grade 6. Grade 1 is usually what we sometimes call diffuse axonal injury, where you have no visible intracranial pathology on CT scan, but still the patient's GCS is 7. 2, you can have 2 and 3 are almost similar, but 2 you have cystans. The basal cystans are the ones you look at, which tells you about edema. You have the cystans are open with a midline shift, which is less than 5 millimeters, or a clot, which is less than 25 cc. 3 is usually when you have a midline shift of less than 5 millimeters, but you have the cystans compressed, which tells you the intracranial pressure is very high, and but there's no mixed density lesion, which is more than 25. Here, there's no much role for surgery. Grade 4 is where you have midline shift of more than 5 millimeters, but the clot is not more than 25. And grade 5 is usually when you have a lesion which can be evacuated surgically, while grade 6 is that you have a large lesion in a location which is not surgically evacuatable. This is the one I'll mention a bit more. You have the Adams classification of diffuse axonal injury, Diffuse axonal injury basically means that because of the severe injury, you have shearings of the neurons for the head injury. And so it can cause shearing. And so it depends. Grade 1 is when you have a diffuse axonal injury seen in the gray white matter. And they usually have brief loss of consciousness. Grade 2 is you will find that you have contusions or hypodensities in the corpus callosum. And here usually you will have comatose, and you don't know how long the patient will be comatose for. Grade 3 is when you have any contusions near the brainstem. And remember, the brainstem is where you have the reticular activating system. And these are the patients who either have severe coma immediately, and they can have either an incomplete recovery, death, or have a permanent vegetative state. What are the principles of management for severe head injury? Still, we'll come back to A, B, C. 1, you want to prevent hypoxia. Remember that the patients who have GCS of 8 or below, they cannot maintain their airway. You have to intubate and mechanically ventilate. You have to target as SpO2 above 90%, and preferably between 94 and 98%. And you have to make sure that if there are any secretions, you have to keep on suctioning PRN. During intubation, you have to be aware that sometimes they may have cervical spine. If you are not sure, you do inline immobilization, where you do 2 of you, one holds the spine in one line, and then you intubate. And if you have either adjuncts for intubation, it's better to use them. 2 is that I won't go so much into rapid sequence intubation, but I've just put it up for your sake. 2 is you want to maintain the map. Sorry, I'll correct that. The new guideline, the 2017 guidelines talk about the map of 90, but they talk about a systolic blood pressure of above 100 in patients who are between 50 and 69, and above 110, systolic blood pressure above 110 in patients who have age between 15 and 49 or above 70 years. So those 2, you want to go for a higher map. So you want to do aggressive fluid resuscitation if it's because of hypovolemia, and sometimes you are forced to use vasopressors like norepinephrine and epinephrine to maintain the maps to allow for cerebral perfusion pressure. HB transfusion you can do if HB is below 10, and sometimes if you have hypertension, you have to remember the triad of Cushing, which talked about hypertension, bradycardia, and the chain-stake breathing. ICP. The whole principle around the management is all the things we have talked about is to prevent ICP, intracranial pressure. And because we know that increased intracranial pressures have been associated with increased morbidity and mortality. And I'll come back a bit before I go to ICP, I'll mention it later. You can maintain prophylactic hypothermia. Some people talk between 32.5 and 34 degrees, and others people between 33.5 and 35 degrees. And the target usually is 34 degrees. You want to start it within 2.5 hours after the injury, and you don't want to use it for more than 48 hours. And the whole aim is to reduce the basic metabolic rate to allow to reduce the requirements of the brain. DVT prophylaxis, I'll come back to hyposmolar because I will go into detail. Usually we go for mechanical and chemical prophylaxis. It's a level 3 evidence, and that you have to balance between the risk of pre-existing clot expanding. So usually we start, if there's a clot, we want to start between 48 to 72 hours after or within 48 hours after surgery. There's no difference between using unfractionated heparin and low molecular weight heparin. And so make it a habit of usually starting low molecular weight heparin. And initially, as you're waiting if the clot is big and you're afraid of bleeding, you can start thromboembolic stockings to avoid DVT. Steroids. In head injury, we don't do so much of randomized control trials because there's a lot of ethical issues, especially denying somebody a treatment which has been shown to be beneficial. But the only level 1 evidence according to the Brain Trauma Foundation guidelines or any guidelines for head injury is steroids. Steroids have been shown to be harmful in patients with severe head injury. So there's no role of steroids in patients with severe head injury. They do not reduce edema. They have been shown to increase infections, interfere with glucose control, and are the only level 1 evidence in head injury, and they show that they are harmful. Nutrition. You want to start nutrition early, and by day 5, you want to achieve the basic catabolic rate. These patients, because of the injury, usually their requirement is 140%, and that it's recommended that starting early nutrition has been shown to reduce mortality and hospital stay. And they recommend transgastric feeding, or what we normally call PEG, percutaneous endoscopic gastrostomy tubes. And that has been shown to reduce the risk of infections. Seizure prophylaxis. The thing you need to remember about seizure prophylaxis is that they don't have a role in late post-traumatic seizures, but they have been shown to be beneficial in early post-traumatic. What do you call early post-traumatic seizures? When the seizure happens within the first 7 days, because anytime you have a seizure during that period, it increases the brain's requirement and can cause worsening of the brain edema. We usually use epinephrine or Keppra, and there's no guidelines could not recommend any superiority between Keppra or epinephrine, and you can use either of the two. If you are using epinephrine, you use 20 milligram per kilo loading dose and 5 to 10 milligram per kilo maintenance dose. And if you are using Keppra, you can start at a dose of 500 to 750 milligram BD, and you can increase to a maximum dose of 3 grams per day until you achieve seizure control. Another thing that I had mentioned is that you need to keep at the back of your mind is that you need to avoid hyperglycemia, because hyperglycemia has been shown to increase the risk of mortality by 20 to 25%. And so you have to make sure you have a tight glycemic control, because they usually get stress ulcers in the ICU. You are supposed to start PPIs, and they did not recommend any superiority of one PPI over the other. I'd gone through this. Usually in our setup, I think we have been trying to push for monitors which you are able to do both ICP monitoring, but currently we are not able to do ICP monitoring. So most of our ICP monitoring, we usually use physical findings. You'll find whether the GCS dropped by 2 or more. If you have a unilaterally dilated pupil, which you didn't have before, a hemiparesis or posturing, and those ones should trigger you to that the ICP is increasing, even though that's very subjective. And so what are the measures you can do? Your first measure initially is you can have a head of the bed elevated to 30 degrees, and that helps with promoting venous return. And also you have to be aware that you have done cervical clearance or you have a cervical collar. 2, you want to reduce the secondary brain insult, hypothermia, hyperglycemia, hypercarbia, and if it's possible, you do ICP monitoring and surgery. After that, sometimes you can go for short-term hyperventilation. It's hypercapnia. You can try to reduce it to 30 to 35 millimeters. Below 30 has been shown to be harmful. And so that one usually helps a bit with you blow out carbon dioxide, because carbon dioxide causes vasodilatation. But if you drop it below 30, you'll get vasoconstriction, which can cause cerebral ischemia, which can worsen. And so you have to keep that at the back of your mind. What are the other options you can do? You can use what is called osmotic therapy. And this one I've put both we use. You can use hypertonic saline. The advantage of hypertonic saline is that one, it increases the CPP and decreases the intracranial pressure. But more importantly, it can be used in hypotension. It has no risk of causing hypotension, 1. And 2, it can be used also in patients who are hypotensive, unlike mannitol. And so you can give it at a rate of 3% saline. You can give it at a rate of 1 ml per kilo per hour. And so if it's 180 kilo person, you can give 80 ml per hour. But the only thing is that you have to monitor your sodium every 6 hours. Mannitol, the commonest, it's an osmotic diuretic, and it has effects on both the ICP, intracranial pressure, the cerebral blood flow, cerebral perfusion pressure, and brain metabolism. And that its half-life is usually 6 hours. You can give it every 6 hours. The only challenge is that it can cause hypotension, and it's also not used in patients who have hypotension. I know usually we say we use it 1 gram per kilo. Remember that for the 20%, the mannitol we have is 20%. And the thing about the 20% mannitol we have, that means it has 20 grams. For every 100 mils, you have 20 grams. If you have a 60 kilo person, you need to give 60 grams. So 60 grams will come to 300 mils every 6 hours. And you have to monitor the output. I've mentioned this, is that it's a temporizing and it's a last resort. And sometimes we can use barbiturate coma. 2 things about barbiturate coma. It's not indicated in the emergency department, 1. 2, it works by reducing, it basically paralyzes, sedates somebody so that you reduce the basic requirements of the brain. But 3, it has not been shown, it has been shown not to have so much in terms of, you cannot use it prophylactically to manage ICP. You just use it when all the other systems fail. Both medical and surgical fails is when you use it. I've talked about anticonvulsants and I've talked about ICP monitoring. This is just a picture I put. This is a person who had an argument with one of his colleagues at work, and he used a nail gun on his head. And you can see how so much motion beam artifacts. And this next scan shows you the nails. And we were able to operate on this patient successfully, and he went home without any neurological deficits. I've just put this for the sake of completion. Sometimes you have this patient who come with a chronic subdural hematoma, and sometimes the patient, because of the sudden deterioration, the relative gives you a red herring sign off that the patient has had a head injury. But what he had was a chronic subdural, which just had a rebleed. And I will just, this is just another patient. You remember the other skull I showed you? Now you can see, if you look at this view, the sagittal or the lateral, you can see that the bullet is superficial. What decides the prognosis? 1 is the clinical severity. If a patient comes in with a low GCS, especially the motor part of the GCS, that one usually you have GCS, then you have the pupils. If you have fixed and dilated pupils or has a decerebrate posturing, that tells you that this is a poor prognosis patient. 2 is the presence of secondary insults. And these ones where you have these patients who have prolonged hypotension, or like I told you about the patient who was referred with a prolonged hypotension with ongoing bleeding, usually that one will worsen the primary injury and that one end up getting poor. 3, structural brain anomalies. In Adams classification grade 3, where a patient has contusions in the brainstem or bleeds in the brainstem, usually the mark of poor. And 4 patients who have coagulopathies or hyperglycemias have been shown to have poor prognosis. Elderly patients have also been shown to have poor. This is the Glasgow outcome scale. We used to use it for patients at discharge and at 6 months, and it was found to be very limiting. And now we use the extended Glasgow outcome scale. And so you'll find that either the patient is deaf or all the way to upper good recovery where they are able to resume. And you'll find that a lot of patients in severe head injury with diffuse axonal either fall in vegetative states or at best case scenario, lower severe disability. This is just a temporal profile. As we start at the acute phase, where you have hemodynamic stability, you prevent secondary injuries, and then you discharge them on the Glasgow outcome scale or the extended. And this is where, in the West and other countries, after we pass this, these patients are usually moved to rehabilitative, and from rehabilitative is the early post-acute, and then from there they move to nursing homes, where they are, if they are connected with the family, they continue the rehabilitation before they are sent back to their homes, if they are able to be accommodated. I will open just quickly, just 1 second. Can you see this one?
Which one, Doc?
Do you see a new slide?
I am seeing the slide with what a day I'm exhausted. Finally, that slide.
No, let me resume sharing.
Okay.
Give me a second. Let me share again. I just want to quickly go through. Can you see?
Yes, I can see TBI pathophysiology.
I'll just go quickly through, for just the sake of completion, through pediatric brain injury. We have discussed the primary injury, and we had discussed the secondary injury, where we aim our treatment. And here, we recommend hypothermia. Hypothermia has been found to be harmful. Usually, you want to avoid hypoxia, and you want to avoid hypocarbia because it keeps CO2 retention. And also, you want to avoid hypotension. Sometimes you may be forced to have hypertension so that you can achieve cerebral perfusion pressure. In terms of head injury, you want to avoid 5% dextrose. 1, because it usually causes hyperglycemia. 2, because it also causes brain edema, because now after you use the glucose, most of the water will become free water, which will cause brain edema. And so that's why you'll find that we are not so keen on dextrose containing. You don't want to restrict fluids because you want to maintain BPs and to maintain urinary output. Same thing. The principles are more or less the same. And I'll jump through this. Usually, most of the places talk about ICP being at the center because it's like treating diabetes without knowing the serum glucose. And that's why you want to have an ICP monitor. And I hope in the future we'll be able to do ICP monitors. Not so much. The only thing it can tell you is their static fractures. Remember, children, because their sutures have not fused, they frequently get their static fractures. And you'll find this is elevated. This is an elevated fracture. This is an elevated fracture, and you can see at the occipital lobe. Sorry, I can't seem to get. Let me see if I can get my pointer. And you can see this patient with what we suspected had a diastatic fracture, and you can see with dural tear when you have widely, and so-called groin skull fractures. I'll jump this one. This is just 2 children, subdural hematoma, not limited by the sutures, and you can see you have subpulsar herniation. You started to get hypodensity, which means that you may start the PCA, the posterior cerebral artery, is also affected, and you can see you can barely see the midline has been pushed completely. So these patients usually get a high risk of getting a PCA impact and an anterior cerebral because the pericallosals run parallel to the falx, and that's the epidural hematoma. I'll just go through. We know when do you operate for this patient? 1, when you have obvious deformity, like a depressed skull fracture. Two, when you have widely diastatic fracture with suspected dural tear, when you have epidural or subdural causing focal brain compression, and a shift, actually it's not 1 centimeter, that shift for more than 5 millimeters. And you can see this is the first scan, you see the fractures, it does not warrant you to operate initially. And sometimes elevated depressed skull fracture, you can do it for cosmesis. A mother will tell you, look, my child has a deformity. There's no way I'm going to allow him to have this ping pong deformity. And sometimes that can trigger you to operate. Sometimes when you have a compound depressed skull fracture and a focal deficits. And I'll just jump this just to show how you open and how an epidural looks like. And remember what I told you, all subdural hematomas are usually associated with diffuse brain injuries, and that the 3 reasons to operate is, one is that when you have a thickness more than 15 millimeters, midline shift more than thickness more than 10, and a midline shift more than 5 millimeters. And those are whether you have herniation syndromes. This is a condition. And if you look at it, it's not a condition which warrants, and this is a condition which doesn't warrant. Sorry, this one I'm just going to go a bit faster through it. All you can appreciate in this scan, and that may warrant maybe to operate, is if medical therapy fails, you are not able to appreciate any sulci or gyri. It just looks very flat. And this one, where you try medical, including ICP, and if it doesn't respond, these are the patients who you can do by frontal decompressive craniotomy. And you can see you couldn't appreciate the distance here. You couldn't appreciate the distance in the first one, and you can see after the decompressive, the last slide, I can't seem to get my pointer, sorry. The last slide, you can see that the brain has opened up, the fourth ventricle has opened, and the temporal horn. And that these are where you have success stories for decompressive craniotomy. What is the challenge with decompressive? What is the challenge with decompressive craniotomy? One, advantages is that it allows shorter ICU stay. Secondly, it allows for reduction of the ICP. But the problem is, it was found to reduce the number of patients who die, but increase the number of patients who are persistently vegetative state. And so you have to have a very long conversation with the relatives to make them understand that there's a high chance that the patient may become persistent vegetative state, and allow them to make the decision whether they want to proceed or not. And I'll not so much go through this. This was, we used to have, at least when I was rotating in Kijabe, we used to have this ICP monitor, and at least it used to help us be able to make those decisions. And our aim is to maintain the cerebral perfusion pressure. I think at that point I will stop so that we can have a discussion.
Thank you very much.
Back to you, Dr.
Thank you. That was a beautiful presentation, very informative. I'm sure everyone has learned a whole lot from it. So we just want to say thank you. But we have a couple of questions from the audience. I think I can just read them. For the ones that have been answered in the presentation, I think maybe we can skip so that we keep time. So there's a question here for, do we give I think this should be antihypertensives. Do we give antihypertensives in head injury? I think probably when we have the Cushing's triad, do we give to settle it? Okay,
2 things. One, if a patient is a non-hypertensive and the blood pressure is high, you can opt for antihypertensives. But most of the time, when you have a hypertension in a patient with head injury with no known underlying, you have to find out, is it because of increased intracranial pressure and ICP is increasing? And so there you don't give antihypertensives, because what you're going to do, you're going to reduce the blood pressure, which is going to reduce the cerebral perfusion pressure, which will cause worse injury. Thank you.
All right, thanks, Doc. The other question is, why is motor score the most important indicator of prognosis when using the GCS relative to eye-opening or verbal response?
I've seen that question in a lot. Because in eye-opening, motor opening is the one which directly correlates with function, and that has been shown in different studies. Remember, the so-called decerebrate posture is almost an abnormal extension. You remember the number 2, it's almost an abnormal extension. And so most studies have shown that when you have the motor has been shown to be a better prognosis from different studies. They don't know the reason why, but it has been shown to be the best in terms of determining prognosis for patients with severe head injury compared to the other 2.
All right, thank you. There's another question here. Kindly comment on features of brain death as predictors of mortality.
Brain death, I've seen, okay. Brain death, brain death is the end stage of brain injury. So it's not even brain death is what we are trying to avoid, especially brainstem death is where we are trying to avoid, because once you get brainstem death, mortality is just a matter of time. And so that's why if you don't sort out all this and then you have persistent high ICP, you're going to get tonsillar herniation. And tonsillar herniation is the brainstem is compressed and the brainstem usually undergoes brainstem death. It's not a predictor of mortality, it's the endpoint of poor outcome, endpoint of very elevated ICP. I don't know if that makes sense.
Yeah, it makes a lot of sense. Thank you. The other 2 are about osmotic therapy. What is the main reason we give mannitol in patients with head injury? Indications of use of hypertonic saline in preventing ICP. But I think those we covered in the presentation. But I've seen another comment requesting just to recap briefly, when do we use the 2, mannitol and hypertonic saline? So maybe we can just cover those 2 together.
When you have, we don't have, the third reality is that we don't have the lack of being able to do ICP monitoring. And hopefully I pray that we have been hoping to get monitors which are monitors for patients and have also ability to do that. My thought process is that whenever you have features of increased ICP, either on CT scan or clinically is when you have reducing in GCS, the people are starting to become unreactive. When you have features of Cushing's or new onset neurological deficits, together with a CT scan, you can give mannitol or hypertonic saline. There's no, in terms of the trauma foundation guidelines, there's no superiority between the 2. It usually recommends mannitol. And so mannitol usually is an osmotic diuretic. So basically it tries to deal with the edema by trying to remove, because it is a big molecule. It remains within the, what is it called? It remains within the vessels. And so it's able to use oncotic pressure to remove water from the brain, hence reducing the pressures. The disadvantage with it is that, one, for patients with kidney injury, especially acute kidney injury, because it's a osmotic diuretic, you have to be very careful. But more importantly, it is patients, you cannot use it on patients who have hypertension, because it will drop the BPs, and the hypertension worsens secondary brain injury. So in patients who are hypertensive, you can use hypertonic saline, because also hypertonic saline, it causes osmosis through, it's more or less the same, it remains within, and because it's a high sodium concentration, it removes water from the brain, causing also a similar diuresis. The only advantage is that it helps to raise the blood pressure, increases cerebral perfusion pressure, but more importantly, it does not have any effect on the map. It does not drop the map, and you can use it for patients who have hypotension. The only thing is that you have to be very careful is that you have to monitor your sodium every 6 hours. I've also seen a question on hyperventilation. Hyperventilation is a temporizing measures. You can do it as you're about to go for a CT scan and the patient has some features of impending herniation. And so usually your target is 30 to 35 millimeters of mercury. And the only problem is, preferably according to the Trauma Foundation guidelines, they talk about starting it within the first 2.5 hours, and you should not use it more than, you shouldn't use it more than 24 hours because of the risks which are associated with hyperventilation. So it's just a temporizing measure, and it's a last resort if your mannitol is not working and other measures. The one for I've seen the ABGA machine, that one I will have to check and get back to you. It's very, don't do it if you don't have the ability to check the BGS.
All right. Thanks, Doc. Just while we're still at that osmotic therapy, in pediatrics, is there any preference between hypertonic saline and mannitol, or any can go?
There's no preference. There's no any, but we like usually the fourth edition usually says start with mannitol. If it's not working is when we usually, because the challenge with mannitol, I forgot to mention, it causes rebound hypertension after if you use it for a long period of time. Unlike hypertonic saline, which doesn't. So after 48 to 72 hours and you still have increased ICP, you can't use mannitol for more than 72 hours because of that risk. You can convert to hypertonic saline.
Right. Thank you. There's another interesting one here. I think this has been, it's been a challenge to all of us. What is the limit of amount of IV fluids for resuscitation, keeping in mind the cerebral edema in traumatic brain injury?
It comes down to ABC. Whatever you use the normal IV fluid resuscitation, because you see the circulation overrides D, which is the brain. So you use the same for the ATLS protocol for fluid resuscitation. And within 20 to 40 minutes, for children, it goes as high as 40 minutes per kilo. And if that's not working now, you convert to blood. And sometimes for suppressors. Bringing the BP up is also of utmost priority, irrespective of the fluids. The only thing is that you need to be able to differentiate between hypovolemic shock and neurogenic shock. Because in neurogenic shock, you have to have you have to limit fluid intake.
All right. Thank you. While we're at it, which would be the choice of fluids in this patient? Normal saline versus ringers, which should we use?
You can use both.
Either is
Sometimes
okay.
we prefer normal saline because you also don't want a high potassium fluid, but you can use both are accepted. The one you avoid is dextrose solutions.
Thank you.
I see Dr. Dede has asked about anticonvulsants.
Yes.
If a patient had a history of convulsions prior to the head injuries, he has to continue his anticonvulsants. Secondly, remember that the anticonvulsant we give in patients with head injury only prevents early post-traumatic seizures, but it has no effect on late post-traumatic seizures. If a patient gets late post-traumatic seizures, which is after 7 days, you treat it as epilepsy. They have a high chance of developing less post-traumatic epilepsy, and now you treat it as a protocol for epilepsy, which I didn't include here.
Right. Thank you. Is there superiority in hypothermia treatment prophylaxis in acute severe brain injury? Or is any study highly recommending it? What are the criteria for selecting a patient for it?
Sorry, repeat.
Is there superiority in hypothermia treatment prophylaxis in acute severe brain injury? Are there any studies highly recommending it? And what is the criteria for selecting a patient for hypothermia treatment?
Hypothermia is recommended. It is usually the target is, sorry, it's usually if you're going to start, You want to start it between 2.5 hours and it lasts for 48 hours. And the evidence is level 3. It's a low level evidence. Level 3B, it's low level evidence. And it has been shown to have no benefit in patients who have diffuse injuries. Those ones who have the brain, there's no surgical evacuatable. They just have diffuse injuries all over with no much edema. They don't have much benefit, like type 1 Marshalls. The dose for mannitol is usually 0.25 or 0. In adults 0.5 to 1 gram, in children 0.25 to 1 gram. And how you calculate, you have for every 100 mils of mannitol has 20 grams. So that whole bottle has 100 grams because it's 20%. So if it's a 60 kilo patient and you decide to go to 1 gram, which is the maximum dose, it will be 60 grams. So if every 20 grams is 100 mils, 60 grams is 300 mils. So you'll give 300 mils. If it's a child and you have decided to calculate as 0.5 and it's 10 kilos, which comes to 5 grams, if 20 grams is 100 mils, 5 grams will be 25 mils. So you'll give 25 mils every 6 hours. Two things. One, you have to run also with IV fluids, because if you diurese without running concurrent IV fluids, you will cause kidney injury. And two, you have to have a catheter in situ to be able to monitor the urine output. There's no role of steroids in mild head injury, moderate head injury, severe head injury, or no all.
Okay. Another question. Could you please comment on depressed skull injury in neonates or infants with a GCS of 15/15?
There are 4 reasons you decide to operate for, 4 or 5 reasons you decide to operate for in neonates and the neonate. One of them is usually if you have a compound skull fracture, if there's a wound above the fracture. 2, if you are suspecting a dural tear because of a depressed skull fracture. And that one, remember, growing skull fracture, so it may look small and you are seeing a small pneumocephalus, but because there's a dural tear, as the child grows, the fracture grows because the brain will try to herniate through the brain. And if you get time, look at what is called growing skull fractures. And sometimes if it's so severe, the outcome is usually very poor. 3, if you suspect any dural tear, as I said. 4, if there's an underlying epidural or subdural hematoma, which needs evacuation. And 5, cosmetic deformities, where you have a big, the brain looks okay, but you have a big deformity on the skull, whether it's frontal. That one now you can operate for. That's one of the reasons you can operate.
All right, thanks. Is there any role for prophylactic antibiotics in patients with head injury?
No, there's no role for prophylactic antibiotic. One of the things in terms of, especially for severe head injury ICU patients, I know ICUs like giving antibiotics, but from the Brain Trauma Foundation guidelines, they even found that early tracheostomy just reduces hospital stay, but it did not have any bearing. It did not have any bearing on, what is it called, on reducing ventilator-associated pneumonia. And secondly, we use a lot of povidone iodine. We use a lot of povidone iodine mouthwashes, and the guidelines don't recommend it. They found that it increased the risk of ARDS, adult respiratory distress syndrome. And so the povidone iodine mouthwashes we have been using to clean their mouth for patients in ICU for head injury has been found to be harmful. So that's also something not recommended. They don't recommend any prophylactic antibiotics unless there's an indication which is independent.
Let me just ask a question on that. What about these patients who have rhinorrhea, otorrhea? Is there any indication for them to be on prophylactic antibiotics?
No, especially if it lasts less than 7 days. Different studies, some studies used to use it, but they found that whether you use prophylactic antibiotics for patients who are used for prophylactic antibiotics and patients who are not used for prophylactic antibiotics, they found there was no difference in terms of the risk of meningitis. So they usually reserve it for treatment doses.
Okay, Thank you. While we are at CSF leaks, there's someone asking, do I have to wait for 2 months, even if the patient has massive rhinorrhea? I think that's about probably.
Yes, I know.
I am.
I think when you have massive rhinorrhea, you have to do another scan to find out the location of the tear. And many a times you may find the location of the tear means near the cribiform is where it has torn, because it's usually adherent. And so you can decide to repeat that. Those ones for massive or significant, you can opt to operate early. Initially, you can try Diamox, and if it doesn't help, acetazolamide, 250 BD, and increase the dose. If it does not help, you can now change them to, you can decide to repair either endonasally using endoscopic technique, or you can do using open craniotomy techniques.
All right, thank you. Something we commonly see in these head injury patients is like they get mental psychiatric like issues. So how do we approach such patients? What's the management for patients who have this mental health
I think
issue?
there are neuropsychiatric manifestations of head injury, and usually I find it easier to manage with psychiatrists, because sometimes, especially patients who have frontal lobe contusions, are the ones who are most because of personality changes, emotional lability. So sometimes I usually don't recommend you using, because you'll find you use a lot of haloperidol or olanzapine, but these are patients you'll want to manage concurrently. Initially, you can even give olanzapine 10 milligrams twice a day, or sometimes even haloperidol, but as you transition the care to a psychiatrist to help with the management.
All right, thank you. Can atropine play any role in head patients?
No, unless you are using it for resuscitation, cardiopulmonary resuscitation.
All right, thank you. Then the last question I'm saying here is, can you use steroids in a patient who has concurrent head and spinal cord injury?
You can use it for the spinal cord injury, but if you go back to NASIS 1, NASIS 2, NASIS 3, which talked about very high dose steroids, the NASIS 3, the argument for steroids is very little, because in the original studies, they found that there was no benefit of steroids because they are using very high doses solumedrol. But now when they did what is called a sub-cohort analysis, where they try now to create sub-cohort analysis, in NASIS 2, they found that there was some benefit of steroids, but whether in terms of spinal cord injury, whether you use it or not, we have not found so much significant changes in terms of neurological outcome. But you can use steroids for other indications other than the head injury, with you understanding the risk of it, especially hyperglycemia, infections, especially those two.
Okay, thank you. I've seen the last question. I think most of the ones I've jumped have already been answered. There are these things that drug reps keep selling us, this cerebroprotein agent. Yes, is there any benefit in these patients? Or are we wasting their money? Does it help?
In my opinion, in my opinion, and also from the data, because there's not much data, the only data which they try to portray are the ones themselves did, is that I haven't seen much benefit. Sometimes you give it for placebo effect, just for the vitamins, but there are no benefits which have been accrued from using it.
Thank you. There's another question I'm seeing here. I think we'll answer this as the last one because we were to conclude at 3:30. Are there situations where you might evacuate intraparenchymal bleeds in head injury?
Yes. When you have one, you have, if it's causing a large mass effect. Two, it is accessible. And if there's midline shift, if there's significant midline shift, all those you can operate.
All right. Thank you very much, Dr. Omar. I think we've covered.
Yeah, welcome. I've seen most people complained I was fast. Sorry. I had a lot to cover.
Yeah, but we have the recording. Yeah, it's okay. We have the recording, which they'll be able to access. So I just want to say thank you to everyone who has attended. thank you to our presenter for the beautiful, beautiful presentation. I've seen many people requesting for the slides. I don't know if Dr. Omar, you're comfortable sharing them with us. But
I'll just edit it a bit and share it.
Oh, perfect.
But you can also share the presentation.
Okay, so thank you.
Yeah, it will be better because it's, yes.
Oh, sorry. The recording will be available. So thank you guys so much. I just want to hand it over to the KNH research team because I've seen there are many questions on the CPD, accessing the CPD. So kindly, Nelson, maybe you can answer the concerns of the audience about accessibility of the CPD points.
Yes, yes, Doc. Yeah. First of all, I'd like to appreciate you being with us for this presentation. We've really learned a lot. And for the CPD points, mostly I can see most of the issues are coming from PPB, that's pharmacy. We are in the process of updating the database on the webinars that we've had, and we are currently sending out the CPD points. We've received some complaints, or rather some concerns from you in terms of the CPD points are not valid, but we are working with the PPB team to get that sorted. So just subscribe to the events. We will be uploading them on the PPB. Subscribe to the events that you did attend in the past, and also the upcoming ones, and we'll send out the CPDs. Thank you.
All right. Thank you, Nelson. I hope everyone's concerns about CPDs have been addressed, and I hope we now can clearly and comfortably handle head injury patients. So thank you very much for the people who've attended, and thank you for the interactive session. Dr. Omar, we appreciate greatly. And I think we can now conclude the meeting. Have a lovely afternoon. Thanks.
Thank you.